Good afternoon, everybody, and welcome to our iGeriCare 13th live event. We're really pleased today, and I'd like to introduce you to our guest expert, Dr. Joanne Ho. Joanne is an assistant professor with McMaster University in divisions of geriatric medicine, and also a clinical pharmacology and toxicology expert in the Department of Medicine. In addition to that, she is a clinical scientist with the Schlegel Research Institute for Aging and the founder of MedRisk. So she's one of the geriatricians and clinical pharmacologists with MedRisk. It's a really interesting and exciting initiative, an interprofessional telemedicine consultation and education program, which supports clinicians across Ontario to try to optimize safe prescribing medications for older adults with complex physical and mental illnesses. And that's been supported by the Ministry of Health in Ontario, as well as our friends at the Centre for Aging and Brain Health Innovation, powered by Baycrest. And a lot of her work on medical education addresses some of the challenges and barriers to safe prescribing and ongoing medication therapy and education for practicing clinicians and med students and other trainees. So great to have you here today. And this is one of the I'm going to say hottest topics out there. Whenever Dr. Stramko and I have talked about some of the medications or treatments and talked about either safer medicines or side effects to medicines, the response, there's a lot of interest in it. And this hot topic of deprescribing has been sort of a new word in the vocabulary of clinicians and doctors. Can we start off just by what exactly is deprescribing?
So thank you very much for having me here on iGeriCare. And I, especially to talk about deprescribing or safe prescribing. And safe prescribing for pretty much everyone. So deprescribing is it's an act to actually remove a medication. But just like prescribing, prior to deprescribing, you need to weigh the risks and the benefits of that act. So when you look at a medication and when you look at that patient, you want to know, is this medication actually going to benefit this patient? Is this medication going to cause harm? Or could this medication be interacting with other medications? And depending on each individual case, you then kind of make the decision that, perhaps for this particular patient, it might be good to pull back on the medication and maybe stop it. The important thing is that it's an intentional act. So it's not something that you just kind of stop doing and you kind of go, oh, well, let's just see. You need to monitor carefully. And I hope to kind of go more into that as kind of the hour goes on, but it's an actual act.
Can you maybe illustrate with a simple example of, what might, how would a caregiver experience the sort of act of deprescribing? How would that happen?
So that's a great question. So I think let's take, for example, sleeping pills. So sleeping pills, they used to be more popular, and their intent was to help people fall asleep. As you get older, these sleeping pills have different effects, and the risk to benefit ratio starts to shift a little bit more into the riskier kind of area for older adults, especially if they have cognitive impairment or dementia.
Okay.
And so one will take a look at that patient and go, how are things going at home? Did this sleeping pill actually give any benefit? But what are the risks also? Is this why maybe they're falling? Maybe is this why they're not as sharp as they used to be? Okay.
And so I guess there might be a wide range of reasons why one might deprescribe, maybe as many reasons as you might prescribe, but maybe just walk through like what are the most common reasons why people would deprescribe, I guess?
So there's a few different reasons. One is if a medication is no longer providing benefit to that particular patient at that time. Number two would be perhaps it's actually causing harm. Maybe they're causing side effects, and that outweigh the benefits to that particular patient. Sometimes also, especially in older adults, we see something called a prescribing cascade. That's where a drug is prescribed to provide benefit to the patient. However, then there's a side effect. However, that side effect isn't recognized as a side effect, and it's thought to be a new disease. And so another medication is loaded on to try to fix the problem, make that patient feel better.
Certainly in psychiatry as well, sometimes we have medicines, and then we have other medicines to help with the management of side effects. So it's like a 2-for-1 cascade.
Exactly. Yeah. So that prescribing cascade does happen quite frequently. And the exciting thing, I think, as a geriatrician and clinical pharmacologist, is that if you can identify the very, the root of that prescribing cascade, then you may actually be able to safely deprescribe multiple medications and actually make the patient feel better.
And I guess, one of the things that we've talked about specifically with dementia is the disease, brings with it memory problems and other cognitive problems. But there are so many types of medicines that might make those memory problems worse, the adverse effects that you're talking about. You mentioned some of them, the sleeping pills. What are some of the other medications, I guess, hot ones that people might, if your caregiver is going with their loved one to see the doctor, what are some of the medicines that might be making memory problems worse that might be a target for deprescribing?
That's a great question. So I would actually kind of divide that up into medications that are prescribed. So say, for example, opioids or certain painkillers. Okay. We know they can affect your brain. Okay, and so that may potentially be worsening someone's memory and thinking. And what we understand more and more is that opioids don't help with all types of pain. And so the risk to benefit, you might not be getting that much help for the pain, but lots of risk. Not just for memory, but also for falls, constipation, sometimes even itchiness. So all of those are pretty important. Then I'd also like to switch into, there's your over-the-counter medications, right? So these are medications that you don't require a prescription for, that are already approved. So these are like your antihistamines. So say if someone's itchy, then they might take diphenhydramine, also known as Benadryl. But there are many generic versions of this. But that medication it can really make it easier for someone to fall, to experience memory issues. And I would say the same thing for dimenhydrinate, also known as Gravol. Okay. There's also, and it's important to let your doctor or your pharmacist or your nurse practitioner know that you are taking these medications because they are important.
So as part of that approach to deprescribing, the family physician or geriatrician should be looking at both prescribed medicines, but also some of the other drugs that people might be taking over the counter that may need to be thoughtfully deprescribed, I guess.
For sure. And sometimes there's the misconception that because you don't need a prescription, they're completely safe. And while they may be safe for many individuals, as we get older, and especially if there is dementia, our bodies change, and how we handle or respond to medications also changes.
I think, what I see frequently in the hospital setting, but I think it also occurs as an outpatient, it's maybe not the cascade necessarily, but I think that it tends to be the case that people prescribe a medicine and seem to forget about it, and then they prescribe another medicine for another condition. It may or may not be a side effect, but there is, am I right in saying that mostly people seem to add more medicines without reevaluating or taking away medicines? Is that?
Absolutely. And I think ultimately everyone wants to try to help, right? And so when they have the patient in front of them, I know that I want to alleviate suffering and help the patient get better. So I can understand that someone would want to try to prescribe, but at the same time, it's important to kind of reevaluate, and especially if, as a clinician, as a doctor, you have that relationship with that patient, you can follow them, you can kind of take a look, take a step back, and go, you know what, you were in hospital, you were really sick, and at that time, because of harm from these symptoms, you needed this medication. Say, for example, an antipsychotic. However, things are different. You're a lot better. And we know there are risks associated with these medications. Let's try to slowly cut back and see if you can do well. Right?
That transition from hospital care back to either long-term care or home seems to be a culprit. Somebody comes in and they've had a fracture and they're prescribed a narcotic or an opioid for the acute pain, but then they forget to take it off, or they're given having trouble sleeping in hospital, so they're given a sleeping pill then, but it just gets continued without being reevaluated.
Yeah.
I agree with you. I think people are trying to do the right thing, but I guess I often explained to patients where this one medicine might have helped with a particular symptom. So you had depression and an antidepressant was started, and then you had anxiety, so a different anti-anxiety medicine was started, and then you had mood swings or things like that, and another medicine was started. And I guess at a certain point you might say, well, there's good science and it's good clinical care to have this one medicine for that symptom, but I think it becomes really hard to tell when there's 3 or 4 or 5. Are those medicines, like the benefits and risk, when there's so many medicines in there, it's like a cocktail and you can't tell whether it's helping or causing adverse effects?
Yes, I totally have to agree, because and a lot of randomized controlled trials that we do in medicine, they often don't include individuals who are living with dementia or who may have multiple medications and multiple comorbidities. And so can you actually generalize all the benefits and lack of harms from some of those studies to the patient who's right in front of you, who may have heart disease, liver disease, kidney disease, dementia, who's been admitted multiple times?
So if you were to, speaking to the caregivers out there, how can a caregiver know if their loved one is taking too many medications?
That's a great question. I think it really depends on, as a caregiver, your loved one the best. Where, who they were like and how they were doing before all the medications kind of started to layer on over the decades or years, if you will. I think it's always great to start communicating, start talking to your doctor, start talking to your pharmacist or nurse practitioner about how are we doing with these medications, and when you do so, I would say it's great if you have a list, or if you on your phone you have something, or a paper list. But I actually recommend the brown bag approach, which was actually developed by a fellow geriatrician. And really what it is, it doesn't have to be brown, just any bag, and just put everything that anyone is taking. It could be blister pack, it could be a pill bottle, anything over the counter, any supplements, any alternative medications, and also please tell your physician or nurse practitioner or pharmacist about any smoking that may be happening, because that can cause drug interactions, any alcohol, how much alcohol, how often, and also if there's cannabis or any other substances that are also being used to maybe provide some relief. But it's important to the prescriber to know about all these different kind of medications and substances, because a lot of them can interact. And even if you want to take one away through drug interactions, if you remove one drug, it can actually affect the levels of the other. So it's so important. Keep those lines of communication open and bring everything, or have that super complete up-to-date list.
I see so many patients in the hospital, many of them struggling with confusion or delirium, and they seem to be on so many medicines. So do we have a sense of the scope of the issue? How many people are on too many medicines, or at least are on multiple medicines? And for me, this seems like a really important and common problem, but I'm wondering do we know how many people in Canada are on too many medicines?
I think it's a great question because in medical literature, you may have heard of the term polypharmacy. So polypharmacy really means multiple medications. However, that itself is also a hot topic. But how each kind of researcher defines polypharmacy also can vary widely from 4 or more medications to 9 or more medications.
Okay.
However, the generally accepted kind of definition is about 5 medications or more. Now, one thing I would say is it's just a number, right? So there are certain conditions where 5 medications or more is actually the standard of care, where all those medications are there to prevent you from hospitalization. So say, for example, if someone just had a heart attack, I wouldn't be surprised if they needed to have aspirin or maybe even another medication to keep their blood nice and thin. They might need a beta blocker or something to keep the heart rate nice and calm. They might need some antihypertensive medication for blood pressure and medication for cholesterol. That's already 5.
So it might be appropriate in some cases.
Absolutely. But sometimes it's also those, even if it's 5 or even 4, sometimes if it's maybe, a sleeping pill and maybe an antipsychotic and, maybe an anti-inflammatory like an NSAID for pain, but it can also raise your blood pressure or affect your kidneys. And as a result, there's another medication for your blood pressure to kind of counteract that. There's some room for improvement.
Okay.
Yep.
Well, let's take some questions, and then we'll probably have some other things that we'll come back to as well. We have a question here. Can non-pharmacological therapies be beneficial to patients living with dementia when medications are no longer beneficial or maybe causing harm? And I think this is something that Dr. Stramko and I have talked about in some of the lessons and sessions that, especially for, managing challenging behaviors or there's the risk benefit, there's really no curative medicine.
Yeah.
And often non-pharmacologic, non-medication approaches are the first and best approach. But it sounds like this is another area where maybe deprescribing comes into play.
Absolutely. Yes, for sure. And I would actually have to, I get to work very closely with Dr. Sophia Benjamin, also a geriatric psychiatrist. And she is co-founder of GeriMedRisk. And we often have cases together or patients where we're both consulted and trying to help out. And often, non-pharmacologic strategies are still extremely important. In fact, so much that with strong kind of non-pharmacologic therapies, we can actually pull back on medications. Right. So especially with dementias, and it's kind of working with the caregiver or also the team, especially if it's in long-term care, to try to identify what might be, if we take, for example, challenging behaviors and responsive behaviors, what are potential triggers or what was important to the patient. And it often takes a lot of creativity in terms of being able to provide a non-pharmacologic therapy, which really works. So it's not always your classic, let's go for a walk. Maybe music was what really appealed to this individual and still does. Maybe there's kind of favorite music. And perhaps just by altering the environment, making it suit just that right person, we can actually make them just have better quality of life, more at ease. And also then there might be fewer kind of what we call responsive behaviors where maybe calling out or being frustrated. Because we're using other means to provide relief, and then we can pull back.
And I think that's one of the extensions of the question where some of these alternative or non-pharmacological therapies, do they need to be when's the best time to introduce them? Should you introduce them while the medications still seem to be beneficial, and maybe when the patient's able to explicitly express how they think they're doing or evaluate it, and what are some of the best steps that need to be taken to determine the effectiveness of those non-pharmacologic therapies? So it sounds like working in a team, trying to be organized and systematic when
Yep.
trying
For sure.
the non-pharmacologic therapies, whether you start them while the person's still on medicines or not. It's just treating it a little bit like a medicine. It's like let's try it.
Absolutely.
Let's do it in an organized, consistent way.
Yep.
Have
and
some
you
way to
monitor,
document
it, and keep the lines of communication open. And you sometimes have to wait and see if it works.
I think with the medications too, I sometimes conceptually talk about it with the caregiver as like any medicine that we're adding, especially in the context of dementia, is treated like a trial. And let's put some time limits on it, put some expectations about reassessing and reevaluating it. And I think that is less likely to lead to the, okay, I started on this sleeping pill and I'm still on it a year later.
Yes, yeah. Exactly.
So I guess, this ties in a little bit with what would you recommend to caregivers? What is it that they can do to facilitate deprescribing or having the conversation about it, I guess?
For sure. And I think that's a great question. So number one is to actually start the conversation with either your doctor, your nurse practitioner, and your pharmacist. Because it's interesting, sometimes physicians, actually a number of studies have shown that sometimes physicians may be nervous about actually bringing up deprescribing because they worry that, oh no, is my patient or their caregiver going to think that I'm giving up on them, right? Even though that's not the case at all, right? So that's one perception among some physicians. So bringing it up, going, do we have to be on all these medications, is a great starter. Number two is bring all of the medications, over-the-counter, herbal medications, prescription medications. Even if you only take it once a week, it's important. Also, tell us about how much smoking, how much alcohol, how much cannabis, or any other substance as well too. And then what will happen is, it's a bit of a partnership. It's kind of having that conversation with doctor, physician, doctor, pharmacist, or nurse practitioner, and really knowing what are the goals of care. What do we really want to achieve for your loved one, right? If it's comfort, if it's also function, sometimes it's very helpful for their prescriber to know, okay, this is what we're really trying to achieve, right?
To have that conversation, to be able to better evaluate the risks and benefits of each one.
Sure.
It's like maybe that's just not of high value to you. You're able to manage the pain well enough without a narcotic. So the side effect on cognition. I think this comes up sometimes with the medicines to help with urinary symptoms or like incontinence, because there's definitely a risk benefit there in terms of memory or side effects. And that's one where I'd say introduce it as a trial very carefully.
Yep.
Is it helping with the symptoms? What's the quality of life? Is it causing memory side effects?
And I like how you introduce the concept when you prescribe as a trial. And I think even for deprescribing, it can also be a trial. Sometimes a medication may actually provide benefit that it's not that apparent until you actually cut down the dose and eventually deprescribe or stop the medication. And if what, through the deprescribing intervention, if you can see, oh, they're getting worse, they were better before, then perhaps that patient really did derive benefit when they were on the previous dose, in which case go back up. And I think a very good example would be some memory medications, some that we use, those cholinesterase inhibitors to treat dementia. Not everyone will benefit, but sometimes it's not that clear who was actually benefiting, right? Yeah.
So we have another question here. Could you comment on the role of statins and the elderly in someone diagnosed with vascular dementia? Are statins used indefinitely to help prevent future events? Is there a cognitive status at which point it no longer makes sense, or an age cutoff?
I think that's a really good question. So what I'm hearing is that with vascular dementia, it implies that strokes have already occurred, Okay, so in medicine, we usually divide things into primary prevention, meaning this is to prevent anything from happening. So and secondary prevention, which is, okay, a stroke has already happened. How do we prevent the next one?
Okay.
So in terms of the benefit, there is still benefit for, there is a role for benefit for statins among those who already have established disease. Now, the question is, what is the patient's goals of care, right? So, and it's, if the patient's goals of care is still to kind of prolong life, preserve function as much as possible, and that there might be a role for the statin. That being said, we know as you get older, the way your body handles medication changes. And so in certain medications, such as statins, in some of them, you may actually have higher levels of statin in the body just because of age alone, in which case you could potentially come down on the dose, okay? But if I can switch over that, if that individual is at a different stage of life and has different goals of care, and perhaps they're in the end of life, there is actually a trial where they actually looked at individuals who are at end of life because of perhaps malignancy or cancer or some other reason. And they actually said, okay, one half of you will be deprescribed, and they were okay with it. You know, obviously with ethics, they were fine with it, and the other half will or were randomized to continuing the statin. And what they found was, in those individuals who were end of life, they actually did better with off the statins, exactly. And so I think it's just a very interesting study because it doesn't necessarily apply to all individuals who are older. However, there is the potential, there is some benefit to deprescribing. Now, I would also have to caution that deprescribing can be associated with risk, right? So say if someone just had a stroke or just had a heart attack, and and there is the chance that if you do not have that statin on board, you could have another heart attack or another stroke, and those can either cause delirium or they can also take away more memory.
And there's definitely a portion of people using statins that may have more severe nerve or muscle problems and muscle weakness. So again, I guess with all of these things, prescribing and deprescribing, it's really looking at those risks and benefits. We have another question here. How long should we give a deprescription before we see if there's a difference? So is there a kind of a standard length, I guess?
Yeah, so that's a great question. So with any deprescribing, it depends on the medication. Okay. So some medications you can stop and there isn't going to be any withdrawal. Or you have to stop it because they're actually having some pretty serious side effects. Right? Okay. But sometimes you have the luxury of being able to stop one at a time or deprescribe and slowly go down one at a time. And then you have to look at the drug, and you also have to look at the disease that it's trying to treat, right? And to the person. And you want to slowly decrease the medication. And sometimes what you're looking at is how long does that drug's effect last in the body? And sometimes it's how long does that drug last in the body? And they're not always the same. So you still need to know the drug really, really well.
Certain drugs that affect the brain, some studies have shown that there can still be evidence of the effects of the medicine in some cases as long as a year later, if there are certain medicines that sort of cross into the brain and don't leave the brain tissue for some time. And also for some of the psychiatric conditions, we know that if you deprescribe too quickly, the risk of a recurrence or a relapse is higher. Now, that isn't necessarily always known with people who have dementia, but I guess it sort of highlights that you have to look at each medicine carefully.
Absolutely.
There have been some studies that have looked at more radical approaches as well, though. I remember reading some studies where they kind of said, well, let's randomize some people to kind of just take them off a bunch of medicines. Now, we wouldn't necessarily recommend that, but I think they showed quite favorable results from it.
Yes, at the same time, and so there are certain situations when stopping things quickly and on your own is, but generally we say just keep the lines of communication open. If you want to, just please keep talking to us because, in hospital, I do see a number of individuals who come in because they stopped medications on their own. They went through withdrawal, right? Or sometimes it's also, a concerned prescriber who is, interested in deprescribing. It's a hot topic now, as you mentioned, and then stopped, but then the body has already, kind of gotten used to certain medications. And if you suddenly take it away, patients can definitely get worse and suffer side effects unnecessarily.
It's probably not fair to come up with catchy generalizations, but I think when we're prescribing for older adults or people with dementia, we often say,
Yes.
start low and go slow. That kind of word of caution might be reasonable in approaching deprescribing.
Absolutely.
Unless there's some, like, as you say, there may be a more emergent situation. And obviously when people come into hospital, they might be delirious. I'm going to say we often look at their list of medicines and may deprescribe fairly rapidly to see if it makes a difference.
At the same time, in hospital, there's also more teams, more eyeballs, more people, the more closer monitoring. If I can also just add in that even when you deprescribe one medication, if that medication is causing a drug interaction, you take that medication away, you need to predict or kind of anticipate the effects of taking away that medication. Right.
What are some of the most common ones of those where the drug-drug interaction is very significant and the deprescribing of the one drug is going to maybe impact on the levels of the other drug? Are there any big ticket ones to mention to people?
Absolutely. So say, for example, there are certain medications to treat seizure. So say, for example, carbamazepine.
Or Tegretol.
Yeah. And it is, and that medication is very interesting because it can actually increase metabolism, the body's metabolism or clearance of other medications. So if you just decrease or just cut the carbamazepine or Tegretol off, you may actually end up with higher levels of other medications.
And potentially toxic
levels.
levels.
Absolutely, exactly. So that would be one example. Sometimes there are medications like certain antidepressants, like paroxetine, fluoxetine, that slow down the rate of clearance of medications. And so if you take that away, then all of a sudden you may actually
bump up some
absolutely.
of the other ones. What about smoking?
Great question.
And I guess the other one that sometimes comes up is grapefruit juice. But let's take the more common thing around smoking and how that might also affect medicines.
Great question. So and especially for any medications used to treat mental illness, really important. So smoking, it's that it can actually increase your body's ability to clear certain medications, specifically cytochrome P450-1A2, which
so these are
sorry,
specialized enzymes in the liver that are used to break down or metabolize a variety of medicines. And again, there's a wide range of different drugs that might inhibit or slow down some of those important chemicals in the liver that break down the drug. So lots of things can cause those interactions.
Sure. And even to the point where, so if someone's smoking, they may actually end up needing more of a certain medication, say of olanzapine or clozapine, in order to provide, to have benefit and to kind of control those disorders. If you stop smoking all of a sudden, maybe because someone's been hospitalized or maybe because someone's moved into a different environment and they can't access that, we know that even within days, that kind of upregulation or that increase in body metabolism of that drug already starts to decrease and go back to normal. And therefore, that patient may actually have much higher levels of those medications, and that can be toxic.
So don't start smoking. That's
Yes, that's even better.
I think it's fair to say smoking is bad for your health
Yes.
and may also cause drug-drug interactions. So we have another question here. This is a question that said, my wife's in late-stage Alzheimer's vascular dementia. There's some recently brought in home caregivers. Hospice is helping. It seems like the meds are excessive. And this is a caregiver who is asking about reducing them, but their impression is the doctor's adding more medicines. You know, does she need 3 Alzheimer's meds, anti-anxiety, antidepressants, antihypertensives, and sleeping pills at this stage? Is this something that you've seen? And
very, very frequently, this
Okay.
is exactly these are the questions posed to me by many physicians and pharmacists and nurse practitioners, and sometimes it's because the patient's caregiver is concerned, going, do they really need to be on all these medications? You know, this is what our goals. These are our goals of care. Are these actually helping? You know, as a geriatrician, clinical pharmacologist, and I know my colleagues in pharmacy and geriatric psychiatry would also add, like, we're more than happy to actually have this conversation and to kind of sort out and figure out which medications are actually giving one the biggest bang for their buck, right? Giving you best value, least risk, and sometimes pill burden itself.
I was going to say, I think that, you know, and maybe if the caregiver is, you know, if the person with dementia is at the point where the caregiver is handing out the medicines, or somebody who's in long-term care and they are dispensed, maybe the pill burden is less of an issue. But to me, it seems like the more medicines and the more frequently they have to take them during the day, the higher the probability that people will make mistakes or won't take them or just get fed up because it's like it's just too many medicines to worry about.
Yes, and I you know, it or maybe not even feel like eating so much, right?
Yeah.
And you know, food it's
just,
very important.
They just ate a handful of pills.
They just ate a handful of pills.
I'm tired of swallowing stuff.
Exactly, and some pills kind of make you nauseous or affect your appetite or give you a funny taste as well in the mouth, and then you won't want to eat as well or as much, and just take away that joy of eating as well.
So actually, this seems like a related question. This is a caregiver who's saying, a tough time getting her husband to take his medications. Sometimes he'll just get fed up and like throw them or hide the bottles or misplace them. What are some of the things that could be done? You mentioned that concept of pill burden. It sounds like this is somebody who's just sick of their medicines.
Yeah. So my approach would be the same. What are the goals of care? Number one, what is the most important thing, or kind of top 3, 5 things to this patient? What do we want to help, or how can we help? Second thing is, what are all the medications? And then you kind of systematically go through and go, does he need all of them, right? Are some of them really still giving benefit? Are some of these causing harm? Could some be causing drug-drug interactions? And maybe causing the prescriber to prescribe some more. And not only that, but also looking at the medication going, interesting, like, are there different formulations, right?
Like a long-acting.
Long-acting,
so the person doesn't have to take it 3 times a day.
Absolutely, or sometimes some can be available through a patch, or
Is it better for people to take more of their medicines at one time, like sort of shifting them to nighttime, and so that it's like, okay, most of your medicines are taken at the same time? Or
yeah, so the research shows that when we want people to kind of take all their medications, you know, the fewer time points where you have to take it. So if you can take it all once a day, then that would be great. That being said, certain medications, if you give them at nighttime or during the day, they can have certain side effects that are undesirable. So it still goes back to the actual time of day. But then also don't forget to look at, I would also say, look at the patient. Sometimes over time with age, your kidneys don't work the same way that they did 30, 40 years ago, right? So clearing the medications may take longer. And in some situations, you don't need to take a medication 4 times a day anymore. Sometimes it might just be twice a day. And if you take it more frequently, you might actually cause harm. So really, it really depends on the medication and also the patient.
Now, I think I'm not sure about all of the different provinces, but in Ontario, I feel like we underutilize pharmacists. Like they can provide great education, and I think in Ontario there is sort of like a consultation that you can book with a pharmacist. Is that something that, are you aware whether that happens in other provinces? And would you agree that that might be another approach to, maybe you have a conversation with a pharmacist and then armed with the results of that conversation, you might talk with the doctor? Or
so pharmacists are one, I mean, they are team members that I consult all the time as well. And I'm very lucky because I get to work with pharmacists every single day. And these are pharmacists in the community, through community pharmacy, and they can, if you're in Ontario, they can do meds checks. And they are great resources. You can liaise with them and you have great relationships with them. So it does help if you usually only have one pharmacy, because then you can form that relationship and then all your medications come from one pharmacy. The other thing is that there are some family health teams in Ontario will actually also have their own pharmacist. Embedded to provide that holistic care. And of course, there's other consultant pharmacists that are around. So at McMaster, we're very lucky. I get to work with pharmacists all the time, and they are, and it's just fantastic.
I would also say that if you're a caregiver and your loved one is admitted to the hospital, that is another opportunity.
Yes.
There are pharmacists that work hand in hand with the clinical teams and maybe use the magic word with your care team of, hey, pharmacy reconciliation. So that process where while the person's in hospital, possibly related to an adverse effect of the medicine, good opportunity to reevaluate and to ensure, though, that there's good communication between the team members and the transition at discharge, so that the community pharmacy and pharmacist and the primary care know what changes have been made. But I think it's a really good opportunity in the hospital setting.
And often many pharmacists will actually reach out to caregivers to ask them about medications, to make sure they have a full list. And even though, yes, maybe the doctor already gave a list, we know that pharmacists are extremely skilled with just having that very just wider lens of picking up everything, over-the-counter, prescription medications, those herbals, and those extra. Or
if there's alternative formulations that
absolutely.
Sometimes the prescribers aren't aware, they write the prescription, and there may be another alternative.
Absolutely.
So I'm going to close off. There was a good tip from one of our caregivers that was sent through. It's not related specifically to deprescribing, but I wanted to share it with caregivers watching today. And that was, even if your family member is semi-active, but they are sitting and sleeping a lot, do continue to check for skin breakdown, pressure points on the skin on a routine basis. It's a lot easier to do that checking and try to prevent skin breakdown or ulcers than to have to manage treatment or manage an infection or an ulcer after the fact. So thank you, viewer, watcher, user of iGeriCare, for sending in that caregiver comment. So I really want to thank Dr. Ho for joining us today. I think this is just such an important topic. It's something that we can all do better on as prescribers, to have a rational approach to medicines. And I think it's a great opportunity for you as a caregiver to advocate on behalf of your loved one, to have that constant reevaluation of, do I need this? Is this the right dose? Are there ways to simplify and reduce the medication burden or adverse effects? So.
If I can just add in one other thing, is that we focus a lot on deprescribing, a hot topic now. However, sometimes if you prescribe the right medication, if you diagnose the appropriate disorder and you prescribe the right medication, you can actually deprescribe very efficiently. So it really is a balance.
Yeah, and I guess to your point previously when talking about non-pharmacological intervention, getting the management approach right, whether with the medicine or not, may also facilitate rational reduction in the number of medicines, sort of the right medicines at the right time.
Right medicine at the right time.
So just want to again thank Dr. Ho. iGeriCare would not have been possible without the support from the Center for Aging and Brain Health Innovation, powered by Baycrest. We have a number of other helpers along the way, the Jarvis Center at Hamilton Health Sciences, McMaster University, the Hamilton Health Sciences Foundation, and the Foundation of the Alzheimer's Society of Hamilton Halton, our Division of E-Learning Innovation team. As usual, this talk is also going to be recorded and available on iGeriCare through the igericare.ca/events URL. So if you want to go back and rewatch it and refer your friends to it, there is a survey pinned at the top of the comment section. So please fill out the survey, provide any suggestions for future live events. Our next live event is Thursday, December 12th. And the topic will be depression and dementia, again with a very special guest, Dr. Joel Sadavoy, who's the creator of the Carers program from Mount Sinai. There is a donate button. So in addition to teamwork making the dream work, your donations help to make it possible to bring these live events to you, to continue to make lessons that will help the lives of caregivers and others. So once again, thanks everybody, and we'll see you next month.